Okay guys, let's get into it. This is the third time I've tried to record this over 2 nights, so it's going to go out now, warts and all, including the hiccups and the coughs and the not quite saying the right thing. Never mind. Nerve entrapments of the foot then. So I'm going to talk about Morton's neuroma, a little bit about tarsal tunnel syndrome, which I think is underdiagnosed, and then I'm going to go through some other nerve entrapments that we see or perhaps may have missed in our clinical practice. And this is based heavily on the lecture that I do for my corticosteroid injection therapy course, CSI, that I do on nerve entrapments. I've been doing that for a few years now, actually since 2006. So yeah, quite a few years. So I regularly do a talk on nerve entrapments, and I concentrate obviously on Morton's neuroma, for which a shot of cortisone is a useful treatment, but it's also very much my go-to for the other nerve entrapments. So we'll go through that. I'm going to try and focus it a little bit more on how this would fit in a neurological session, but bear in mind that, as I say, when I do this talk normally it's based on injection therapy. And I'm also repurposing it for the talk that I'm doing next month with Dr. John Darlington, who's a much too good looking for my liking young doctor up in Glasgow. So John and I were going to be running some neurology update for podiatrists, and we've got a bit of an ambition. Actually, it's probably more John's ambition than mine, and we want to help people who are a little bit rusty on neurological assessment. He's the medic in the group. He's got an amazing knowledge on all things medical, but it's how, with the talk that's aimed at podiatrists, it's how we as a professional group of pods would pick up on neurological disorders, what our role might be in that. It might be to help diagnose, it might be to refer on. But within that world of neurology, a lot of the times that we see neurological dysfunction, it's actually a local nerve entrapment. So I think that's kind of where I come in. So I put a little video up a few nights ago on anterior tarsal tunnel syndrome, and probably really these two videos are asked about face in terms of I should have done the wider talk on nerve entrapments and then spent a bit more time talking about the detail of anterior tarsal tunnel syndrome. But I had that little video that I just of a patient. I just wanted to get that one up and done, and tried and failed 3 times to record this one. So this is going out warts and all. And nervous system organisation of, I always like to throw this in when I'm talking all things neuro, whether I'm talking nerve entrapments or if I'm doing something on neurological assessment. It's been quite interesting updating my slides with John, because it's something that I used to teach 20 odd years ago when I was a lecturer at the School of Podiatry in Northampton. So it often fell to me to kind of do the neuro assessment lectures, and we've been updating them a lot the last few months, John and I. So I think they're going to hopefully be of a higher stamp. But this is, as I say, I have this when I have my neuro talk, or really any neuro talk, in terms of how is the nervous system organised. So I'll say this and I'll start this, and people will go, oh, sympathetic and blah blah. It's like no, way too soon. So it's going to break down into central nervous system and peripheral nervous system in terms of how these neurological tissues are organised. And the central nervous system will break down into the brain and the spinal cord. The peripheral will break down into the afferent sensory system, that's taking impulses from the body back to the brain, which the brain will then interpret, or out to the body. So efferent system. So for efferent, think effluent. So it's going away from the brain, either to the muscles or the giblets. And then the autonomic breaks down into the sympathetic and the parasympathetic, and the afferent breaks down into the somatic sensory and the visceral sensory. So we're clearly talking about, let me see if I can pull up a pointer. Oh, there you go. So we're really thinking about the peripheral nervous system in terms of peripheral nerve entrapments. But bear in mind that if we have a proximal enough entrapment, that we might see afferent, skeletal and autonomic effects because of that entrapment. So think sciatica. Spinal cord then, having said, let me just move that little mouse off to the side. So having said that the spinal cord is part of the central nervous system, then the next thing to think about is the dermatome, which is an area of skin supplied by an individual dorsal nerve root. So it's very useful as jobbing pods to be aware of where the dermatomes are. And you can look online and look in the anatomy books, and they sort of help you out and say, yeah, this is where they all go. But I think in fairness, it's one of the reasons that John and I are looking to do the course, is that I think a lot of pods are a little bit rusty in this area and or never actually knew it. Now, I remember being taught this back in the day by Pete Bowden, who was my lecturer at Salford for gross anatomy, and Rob Kidd, who did morbid anatomy. So we had an excellent instruction. It was 2 years we did at Salford back in the 80s. So we had really good instruction in anatomy, and I think that lays the groundwork. And one of the things I'm forever banging on about to pods is knowing your anatomy, because if you don't know your anatomy, you can't diagnose. You've got to know what's there before you can understand what's not working well. So I'm just pinch this off the web, but with credit. I really like this this video that this young physio guy had done. So let's just borrow this with credit to go through dermatomes.
In this video, we are going to look at dermatome testing of the lower extremity. Hi and welcome back to Physio Tutors. Dermatome assessment is an essential part of neurological examination when suspecting radiculopathy, as changes in sensation within a specific dermatome may help you identify the pathological disc level. Al-Nazari et al. From 2013 performed a systematic review and meta-analysis of 14 different studies investigating sensory, motor and reflex testing for lumbar disc herniations. The results showed that sensory testing had a sensitivity of 32 to 40% and a specificity of 59 to 72%, which translated to a sensitivity of 35 and a specificity of 64% in the identification of the pathological disc level. Pooled positive likelihood ratios for all neurological examination components ranged between 1.02 and 1.26, so positive or negative findings don't raise the post-test probability much at all, which is why we attribute this assessment a rather weak clinical value. Despite these findings, it's still the best tool we have in physical assessment. In the lower extremity, nerve root compromise is most often seen on L4, L5 and L5S1 level, followed by a far less incidence on L3, L4 and rarely on levels above that.
Sensory testing for the lower extremity is done with the patient in supine and the lower extremities exposed. Use a brush like the one found in the handle of most reflex hammers and stroke the dermatomal regions on both the affected and unaffected limb and ask the patient whether they feel side-by-side differences.
Alright guys, there you have it. If you want to learn about special tests to assess radicular pain, check out our video on the popular straight leg raise test. Click the link in the top right corner or check the links in the video description if you want to find out about ways how you can support this channel. As always, if you like this video, give it a thumbs up and subscribe if you haven't. This was Andreas for Physio Tutors. Thanks for watching and I'll see you next time. Bye.
Yes, Andreas, nice job there, and a little bit jealous about your intro and your outro because they're a bit better than mine. There are, of course, a range of different dermatome clips online. This is another one I had a look at. I thought this was really nice. But just as a kind of a caveat, really, I've long since noticed when I try and keep in the books and find new apps, you will find some variation in anatomy from book to book. So there's a paper that I found: conflicting dermatome maps, educational and clinical implications. So you do have to watch a little bit what you see from book to book and from app to app. And I've seen some absolute howlers in some really good books in terms of, I really don't think that's correct. So take for instance this is from McMinn's, I think, which is one of my favourite anatomy books. In blue, tibial nerve. Now, really, is that the tibial nerve? No, it's not really, is it? That's going to be, in terms of skin supply, the medial calcaneal nerve. All of this is the tibial nerve. I mean, the tibial nerve splits into three. So medial calc will be the first branch off, and then the medial and lateral plantar nerve. That separate at the fourth toe. So you have the medial 3.5 and the lateral 1.5 toes. So while it's great to know about dermatomes, and I think that would be a very useful knowledge base to have, if we're thinking about nerve entrapments, we're actually more bothered about the actual peripheral nerve roots and where they may come to be entrapped. But bear in mind that we're not all made the same. And I could talk a little bit about variations of anatomy in perhaps another lecture. And if you wanted a reference, the reference for that would be Serafian. However, I digress. So let's have a little look at entrapment neuropathies. Now, I'm hopeful that some of you will get the humour of this. This, of course, is the Chinese finger trap, and this, of course, is Admiral Akbar. You may or may not get the humour of that. If you don't, drop me an email and I shall tell you. So entrapment neuropathies are a group of disorders of the peripheral nerves characterised by pain and or loss of function of the nerves as a result of chronic compression, and the symptoms can be motor, sensory or autonomic, as I mentioned a few slides ago. And if you want to really dig deep into entrapment neuropathies and to see what happens to the nerves in long-term compression and how they will often break down and become damaged, then that's a whole other rabbit hole you can go down if you would like. And I'm just going to move that mouse to the bottom right hand corner. So they're really quite common despite what we're taught in podiatry school. So elements of my undergraduate diploma training were excellent looking back, really good anatomy knowledge, but a little bit didactic in terms of some of what I would call podiatry or podology in terms of foot conditions, kind of MSK. To be fair, I qualified about 1 million years ago, so a lot of that has changed. But a lot of the training I have, I remain grateful for, and I'm just going to single out Robert Kidd again, who's one of my favourite people in the planet, in the profession. So anyway, really quite common despite what we're taught in podiatry school, and in fact there's a whole book on it. So I've got that book, and it's there's some podiatry involvement in the foot and ankle stuff. It's not, I don't agree with absolutely all of it, but it's worth checking out. It's quite a useful book. So peripheral nerve entrapment occurs, I'm just going to move that mouse again, occurs at anatomical sites where the nerve maybe changes direction to enter a fibro or a fibroosseous tunnel, or maybe where the nerve passes over a fibrous or muscular band or a bone, and it's because there's some mechanically induced irritation likely to occur at those sites. And that's an old reference from Capel and Thompson, but I'll certainly go with that. The physical examination is quite specific. It will typically have you saying to the patient, where does it hurt? You will perhaps say, what is your main symptom? Then they will say pain, and you will maybe follow that up with say, well, what type of pain? Sharp, shooting, aching, burning. Once you've you've teed into it being a neuralgic type pain. It's where does it hurt, and they'll be able to say it hurts there. The normal nerves, a lot of which you can palpate, you can roll under your thumb, will be insensitive. When you roll a nerve under your thumb, you're not likely to cause pain. You might get a little bit of a mild tingling or tinels, but an inflamed entrapped nerve will often be quite sensitive. And that's where really we're going to come into the Tinel sign, or correctly known as the Hoffman-Tinel sign. And two different authors, actually on either side of the First World War, one German, one French, wrote this up in 1915. So we know it really as Tinel sign. I'm always a big fan in going to the primary reference to see what the original authors said. And it's basically a percussing or tapping of the nerve. So this is from that first video that I put up a few days ago. So this is kind of tapping. Obviously you can't see it in a kind of still picture, but tapping on the deep peroneal nerve to elicit radiating pain going distally. Now I've occasionally seen that pain radiate proximally, but typically you'd be tapping on the point of entrapment and you get a distal radiation of neuralgic pain, as opposed to Valix phenomenon or Valix sign. So I've heard people say that if you tap on a nerve and you get distal radiation of pain, that's Tinel sign, and if that pain radiates proximally, then that's Valix sign or Valix phenomenon. So no, not true. Go to the original reference. Now, not that I've looked at the original reference in French, but I've certainly looked at people who've translated it. So Valix phenomenon is producing pain at points along the course of the nerve, but particularly local soreness. So here's a tarsal tunnel case that I had. We'll use some of these pictures later on in this presentation. When I see a tarsal tunnel, quite often because the nerve's so deep in underneath the abductor hallucis muscle, you will often not generate a Tinel sign. But if you press on that and you get a local soreness, in which you can occasionally along the course of the nerve, then that's Valix phenomenon or Valix sign. Okay, so imaging. So generally we would say for a nerve entrapment that MRI is the best imaging modality. I'll caveat that in a bit when we talk about Morton's neuroma. And a small nerve will often not show a definitive abnormality itself, quite often due to the spatial resolution, i.e. the nerve is so bloody small, you won't often see the nerve entrapment. So very often, particularly if I'm scanning for tarsal tunnel, it'll come back as negative, and I'll say when I'm requesting for the scan, query tarsal tunnel syndrome, for example, for a space occupying lesion, and very often the scan will come back and say, normal tarsal tunnel, i.e. there's nothing within the tarsal tunnel that's compressing the nerve. But what you may see, particularly in late changes, is the nerve that innervates the muscles, or rather the muscles innervated by the nerve that's trapped, will often become a bit weak and a bit fatty. And so you'll see changes within the musculature, which is what the MRI will pick up best. Okay, so let's come into plantar digital neuritis. I'm going to say AKA Morton's neuroma, but really not quite, because if we're being pedantic, and I'm known to be a bit pedantic, all the different common digital nerves have their own eponymous nomenclature. So Joplin's, Hutter's, Hauser's, Morton's, Island's, respectively, from medial to lateral. So I'll see Joplin's from time to time. Hutter's I've never seen, except the one time I caused it, taking out a lipoma underneath the foot and caused a nerve entrapment. Hauser's I do see fairly commonly, and it will often run with a hammer toe. But the Hauser's neuroma is nearly always smaller than a Morton's when I take them out surgically. It's sometimes difficult, I think, to differentiate between a swollen second MTPJ, which we see a lot with capsulitis. In fact, I saw somebody post a picture on Facebook just today of what was clearly a hammer toe with some bursitis that the podiatrist thought might be cancer and needed to be referred on. I had to sit on my hands for that one when I replied, I'll tell you. And you'll often get some swelling of the joint pressing on a nerve. So watch out for that patient that's got a hammer second toe and you think you've got a neuroma because there are neuralgic symptoms, but it's actually the joint swelling pressing on the nerve. Having taken out, heck, I don't know, 100 different house and neuromas over the years, they're nearly always smaller. Okay, moving on. So let's just review the anatomy just for a sec. So the common digital nerves originate from the medial and the lateral plantar nerves, and they course forward into the foot. We're talking plantally now. And the medial plantar nerve divides into the medial 3 common digital nerves, and they branch to supply adjacent sides of the medial 3.5 toes, and the lateral plantar nerve supplies the lateral 1.5 digits. So common digital nerve bifurcating into a proper digital nerve. And then branches from those nerves unite around the 3rd and 4th toes of the 3rd intermetatarsal space. So there's physically more nerve tissue within that interspace, which is one of the reasons why we'll see more Morton's neuroma at that site. And then we'll get the most marked angulation of the nerve at that point as it goes underneath the deep transverse metatarsal ligament and courses forward into the toes. And so that can be one of the points that the Morton's neuroma, if we're thinking about the 3rd interspace. I'm just going to bring that mouse in because I'm going to use it in the next slide or two. Can be entrapped. So I'm just going to highlight that. I'll come back to that in a sec. Definition: perineural fibrosis or bursa of the plantar nerve, and it's very often. Oh, I've gone too far on right. This is what I mean when I'm going to say, "Oh bloody hell." This is where I'm going to say you're having this presentation warts and all now. So the last bullet point on that list said what was wrong with that previous picture, and what it showed was the nerve being caught between the metatarsal heads, and that's not where the Morton's neuroma form. So we've got our nerve coming deep to the deep transverse metatarsal ligament, and so this is our common digital nerve, and then it splits into the proper digital nerves. So at this point here, the nerve is deep to the metatarsal heads. So when we say Morton's neuromas form between the metatarsal heads, they can't do, because the nerve is plantar to. Here's a better schematic. So here's our deep transverse metatarsal ligament. Here are our neurovascular structures. So there's no way you can actually get a Morton's neuroma form between the met heads here. Actually, this is where you get an intermetatarsal bursitis on its own, just a primary bursitis you'll see with a hypermobile foot. So you'll get the nerve being caught maybe underneath the deep transverse metatarsal ligament and a met head, or more likely a base of proximal phalanx. Oftentimes that nerve entrapment is more distal. So as I said, there's a connecting branch between the medial and lateral plantar nerves. So let's just show that. So here we've got deep structures. Let's put in some neurovascular structures, and then at that point there's very often, but not always, a communicating branch between the medial and lateral plantar nerves, but deep to the deep transverse metatarsal ligament. So oftentimes where you see the neuroma form is about that point there. And it honestly, I've taken out nearly 500 now. 2nd, 3rd and 4th interspace, it really is. And what's the mechanism of irritation? So compression of the nerve mostly, stretching of the nerve. Nerve tissue is very inelastic, it doesn't like to be stretched. Maybe there's some nerve ischemia going on in a combination of those to cause some perineural fibrosis and bursa. So when we scan these, they'll often come back as a Morton's neuroma bursal complex. There's nearly always a bursa surrounding the nerve, but points to note is it's more distal than you think. Symptoms would be neuralgic burning pain in the 3rd web space, 3rd if it's just a Morton's neuroma, possibly with numbness in the affected toe, so 3rd and 4th toes might be numb. That might have radiating pain up until the 3rd and the 4th toes. What makes it worse? Well, worse with excuse me, tight shoes. What makes it better? Well, removing the shoe and massaging the foot. So this is your typically female wearing typically a tighter shoe, typically with a bit of a heel, which will be I'm putting the nerve on stretch, and there'll be, I'm going to sound casually sexist now, but they'll be in town shopping, and they'll stop and look in a window, and that's kind of one of those classic signs in the literature to say they've not really stopped to look in the window. They've actually stopped just to take the shoe off and just massage the foot. Differential, well, you're going to see problems with the joints, so capsulitis, synovitis, particularly the second MTPJ. Could be a bursitis, and that could be an intermetatarsal bursitis. You'll see with a hypermobile foot. I've seen a few of those. No neuroma, but a pure intermetatarsal bursa, which is more proximal, is properly between the metatarsal heads, and is properly in the middle of the foot as opposed to deep to the deep transverse metatarsal ligament. Could be a plantar plate rupture, particularly on a second toe. So really, really watch out for that second toe. It's unusual, very unusual, to see an isolated Hauser's neuroma in that second ray. There's nearly always a mechanical overload. Could be other nerve pathology. I've seen occasionally people who've had, say, a tarsal tunnel with symptoms radiating distally being referred through as a Morton's neuroma, or you could have a nerve tumour as well. Could be a fracture. So I've seen patients with stress fractures sent through saying, please see my patient with a Morton's neuroma, and it's been a stress fracture. Could be osteoarthritis of classically the second MTPJ, so a Freiberg's infraction, not infarction, Freiberg's infraction, masquerading as a neuroma. Or I've even had patients sent through from GPs saying, please see this patient with a Morton's neuroma, and it's been a corn. I kiddeth you not. So the clinician should look for point tenderness between and anterior to the adjacent metatarsal head, stroke phalanges, and not be surprised to find that the point is somewhat more distal than is often thought. So that's from one of the American College of Foot and Ankle Surgeons guidelines, which are readily available on the internet and excellent. Really good points to start your wider reading with. So our sensory distribution of that common digital nerve splitting into the proper digital nerves will be there. And clinical tests. So there are a range. Mulder's clip will be the classic one we'll go on to in a sec, but there are others. So we've got Gauthiers, Brutowski's, Cloak and Grice, and a positive Tinel sign of radiating pain. Now, I can't see that I don't really percuss the nerve. That's not really what I go for. I go for really what is a kind of a Valix phenomenon type process, as in local tenderness when I press on it. That's made me think there, really. Yeah, I don't actually percuss it in a Tinel sign. Do you know what? I'm going to try it tomorrow. I'm sure I'll have a Morton's neuroma patient in tomorrow.
Can you see that clunking? Let's see if that kind of clumps up. Can you see that clunking?
This is on loop, so this is an old video of mine. So you can actually see.
That kind of clumps up.
So I'm applying medial and lateral pressure, dorsiflexing between the third and fourth, and you can often really feel it clunking around. So that for me is my version of a Mulder's, and almost that local tenderness I think you could call a bit more Valix. So some pictures that the legend that is Ian Griffiths has put together for the different eponyms for his sports podiatry channel. They look really nice here, and good job. He's obviously used with permission. One of my best buds is young Mr. Griffiths. So there's Mulder's. Now there's Gauthier's, which is a little bit more pressing down on the toes. I'm just going to move that mouse off to one corner. Brutowski's and Cloak and Grice. Magdi Grice was a very, very capable orthopedic surgeon, worked up in Cumbria when I was there about 20 odd years ago. So he'd actually talked about the digital stretch test. So there's a range of different tests that you can use, but I think my version of the Mulder seems to work pretty well for me. Sullivan's sign. So okay, this is what I was taught back in the day: spreading of the toe. So Sullivan's sign, in terms of a clinical sign, or on an X-ray, you might call it Churchill sign. So this is definitely what I was taught, and I certainly see other people referencing this, and I don't buy it for a moment. I would say I've taken out about 500 neuromas, and apart from the biggest chunky monkeys, they're normally about the thickness of a pencil. When you think the normal nerves would be thickness of a pencil lead, and they're a little bit more distal than we think. And I just don't buy that these small benign tumours actually push the toes apart. I think it's much more that you've got metatarsophalangeal joint involvement. That's my view. Happy to be challenged on that. So imaging. So having said that MRIs are really best for nerve entrapments generally, for Morton's neuroma you could use an MRI to actually see the neuroma bursal complex. So these will actually show up just because they're accompanied by fluid. But ultrasound is pretty much the better overall technique. And if this could be another whole lecture on ultrasound versus MRI to diagnose a Morton's neuroma, in fact it probably should be a lecture. It certainly could be a lecture because there's lots of papers talking about the pros and cons. Somewhat operator dependent is ultrasound, i.e. is the person doing it any bloody good? If you gave me an ultrasound probe, I might see it because I'm not an experienced sonographer. I can get by, but it needs to be in the hands of somebody who actually knows how to use a probe. And there you go. The site of entrapment is normally distal, so I think I've probably made that point enough. But we're all taught they're between the third and fourth metatarsal heads. They aren't.
This is a lady with a 2-year history of right forefoot pain, which she feels is centred around the third toe. So the provisional diagnosis is that of a Morton's neuroma, and we're just going to scan her today to confirm the diagnosis. And I usually like to start off in the longitudinal plane on the plantar aspect of the foot. And what I'm doing now is I'm scanning in the fifth metatarsal interspace, showing a normal interspace there, which is really composed of echogenic reflective tissue, which is connective tissue and fat. And what I'm doing now is I'm going over to the medial side of the foot. What you can see there is the fourth metatarsophalangeal joint with a flexor tendon running underneath. And as we go over more medially now, we're in the fourth metatarsal interspace. And you can see in the center of the screen there's a poorly reflective or dark area here, which corresponds to the Morton's neuroma, which I'm indicating there with the arrow. What I sometimes do in these cases is now apply some pressure on the dorsal aspect of the foot, which occasionally brings on the patient's symptoms. Does that painful for you?
Not today.
Not today. And the other thing I find what's useful with this is often the Morton's neuroma is associated with some bursitis, and with the compression as the bursitis compresses away, which I'm just indicating here, which is this area underneath the neuroma, that darker area. As I'm compressing it, that pushes away, and then this area persists, that's the neuroma there. And the other thing what we can sometimes do is go into the transverse plane. So what we have here is the fourth metatarsal head and the third metatarsal head, and we're just looking at this darker area between the metatarsal heads here. So again, that's the neuroma. And what I'm doing is just squeezing the foot, and you can see sometimes the neuroma squashing out between the metatarsal heads there at the top of the screen, and occasionally that is accompanied by a clicking sound, which we call the Mulder's click.
So that is from the third edition of Merriman's, sorry Linda, Merriman's Assessment of the Lower Limb. I was author of chapters in the second and third edition. Ben Yates' current editor. I say current, crumbs, how old is that book now? Oh, heck, I want to say 15 years since we wrote that book. So anyway, those are used with permission. Thank you, Ben. Treatment. So would be avoiding tight-fitting shoes. If you get somebody early, get them to avoid those shoes. Obviously, typically would be a female patient. I've certainly found if you get in with orthotics or a shaft pad early doors, then that can be of help. As I say, this talk comes very much from my injection therapy course, so I'm all about putting some steroid in, and then obviously surgery for failed conservative management. And just in case you're interested, this is how I inject an interdigital neuroma. I use a small syringe. I'll use a 23 gauge needle to draw the steroid up with, but I'll inject with a 21 gauge, usually methylprednisolone, depomedrone, often with a little smidge of a local anaesthetic. So I'll palpate the intermetatarsal space, look to visualise where the MTPJs are, and start dorsally, going through the foot, holding the needle lightly at 90 degrees to the skin. It says look for needle paresthesia. Well, that's what we kind of used to teach back in the days. That should probably really now say look to avoid needle paresthesia. You'll often get some ouchy symptoms when you inject. What we used to teach way back in the day was almost looking to find the neuroma with the needle. So yeah, that should really say look to avoid needle paresthesia. I'm going to change that actually. Remember that the nerve is plantar, but if you go too far from dorsal to plantar, you'll be scratching and pinpricking the inside of the skin with the needle, and in which case you're more likely to cause some lipoatrophy. Not a good thing. Talk to the patient while you're doing it, and they may well jump, particularly if you scratch the plantar skin or if you scratch the neuroma. I've seen 1,001 patients who've ended up with a moderate neuropraxia from a cortisone shot scratching that big old swollen nerve. So this is from my injection therapy book I did with Stuart Metcalf. This was 2010, so this is 15 years ago. So just kind of demonstrating about where to inject, and I'll often just to show you, and perhaps over egging it slightly, but how far distal that those neuroma can be. But injecting from a dorsal approach is the kindest. So holding the syringe lightly because the patient may well jump. But you're effectively going through the foot. Need to be a bit more careful with that bloody mouse. Right, so this is me doing a plantar approach for surgery. I'm very much a fan of a plantar approach. There's a whole other lecture that I've given a couple of times because it's a plantar nerve. And again, we were taught in chiropody school, don't cut through the plantar surface of the foot. Yes, it's not as black and white as that, guys. So plantar is my go-to. And in fact, just tonight, one of my Australian pod surgery buddies has put a YouTube video up on plantar approach for Morton's neuroma. I've been trying to book the trend over the last 15 years since I moved to a plantar approach. The reasons for that is when I used to do dorsal approaches, here's my incision from a Hauser's neuroma, and the scar actually contracted. You can see it's actually pulled the second toe up. So about 15 years ago, I switched from dorsal to plantar, and I've never looked back. Hardly ever looked back. So Morton's neuroma, I think we're kind of familiar with that, but in terms of a summary, think about the different interspaces. If it's a second interspace, you've probably got some overload. You've almost definitely, you've got some overload with the second ray. Isolated second interspace neuromas are as rare as the teeth of a hen. When you do see Morton's neuroma, the third interspace version, it's more distal, and then treat accordingly. Now, tarsal tunnel syndrome, again, it's not quite how I was taught. So I think I see this at least every other week. I think it's massively underdiagnosed. The tarsal canal is located behind and under the median malleolus and becomes the tarsal tunnel as a result of the flexor retinaculum, also known as the Lysiniate ligament, passing over it and creating a closed space. So you've got bone underneath and retinaculum over the top. The retinaculum itself blends with the plantar fascia, and therefore when you see patients who've got tension on the fascia, so are overpronating patients, overpronation is still a thing, Mr. Griffiths, you will often see a change really in the volume of the tarsal canal. From the underside of that, flexor retinaculum receptor emerge and go deep to the bone, so that we have tendon, vein, artery, vein, nerve, and tendon within 4 different septa. And the bifurcated tibial nerve enters the foot at the abductor canal, which is typically referred to as the portopedis. So when I do my local anaesthetic days and I say, what is the portopedis? Normally in a room of 20, there's 1 or 2 that have heard of the portopedis. I don't remember this at pod school, maybe I missed it out, but it's, if you don't know where the portopedis is, you're missing the majority of tarsal tunnel syndromes, because the majority, we think now about 80% of the time that we see a tarsal tunnel syndrome, it's distal. You can get a proximal and a distal, but I'll come to that with some pictures in a sec. So let's throw in from good old primal pictures. So there's the bones. Let's put some layers on that. So we'll put some ligaments in, we'll put a few more ligaments in, some tendons in, some more tendons in. Okay, so here now is our flexor retinaculum, our laciniate ligament, and then we'll put in our tubing. So to be honest, that's a little bit far back, just a little bit far back, because the nerves are right on the tubes, but where they come into the foot at this point here, underneath the abductor hallucis muscle belly, so that abductor canal, aka the portopedis, is where you'll see most tarsal tunnel syndrome, and it's oftentimes it's an entrapment at that point there. You can get, as we were taught, an entrapment anywhere along. I mean, I've actually got one lady who's got a problem up here, but it's unusual. Most of the time it's more distal. And again, you'll find lots of nice little pictures online. The nerve at this point is posterior lateral to the artery, so that is your landmark. But where you want to be able to follow the artery down, so you know where the nerve is in relation to the artery. But you're really looking then for the muscle belly of abductor hallucis, and in that overpronating, maybe higher BMI patient, you'll have a hypertrophied abductor hallucis muscle belly, and I think that's the bad guy 8 times out of 10. I really do. So tarsal tunnel syndrome describes an entrapment or compressional neuropathy of the tibial nerve in the posterior medial compartment of the foot, and this will be where you may or may not see some sensory involvement. What you're going to do, you're going to get the patient standing, look at their range of motion, percuss the nerve, you're looking for irritability. So if we're saying percussion, we're thinking Tinel's. I can't say that I do that. What I really do is I look for Valix phenomenon. I'm looking for local soreness at the portopedis. Palpate for any obvious soft tissue masses. You're not commonly going to be able to feel those, but I will scan. So I'm looking for those, and I'll occasionally pick those up. We'll have some pictures in a minute. Nerve conduction test, looking at nerve conduction velocity. I used to do 15, 20 years ago, and I've kind of gone off from doing that because I really found that if I had patients who had neuralgic symptoms and a positive physical examination, that I didn't need that 3 out of 3 positive nerve conduction test. So I've not referred off one of those in about 15 years. Sensory examination is often of little help, so motor weakness will be a late finding, which you'll see on a scan, particularly abductor hallucis, but depending on how proximal the entrapment is, maybe all the plantar muscles. So it tends to be a later finding, and by sensory examination, that sharp, blunt, hot, cold, light touch, all of that great stuff we're going to go through on the neuro course. I find not a lot of help. The biggest thing that I'm looking for is neuralgic pain and local tenderness. I'll do x-rays if I'm suspecting a bony lesion. On rare occasions I'll see an old calc fracture or a coalition causing the trouble, but I'm thinking particularly of a space occupying lesion, and the big culprits there would be lipomas or particularly varicose veins. So there's an overlap between patients that have fascial pathologies or plantar fasciitis, don't we just love it, patients that have got nerve compression, and patients that have had problems with the heel pad or even post-tib dysfunction. That's kind of like a classic triad of a little bit of post-tib dysfunction, plantar fasciitis, and maybe some tarsal tunnel syndrome. But I would say 20% of the time I see patients with fasciitis, there's some nerve compression involved as well, and that's not just me saying, that's other authors as well. So when you've got your patient that presents with heel pain, have a look at the abductor canal, portopedis. You will be surprised how often you find patients with local soreness at that point. And as if to kind of egg the point. This is the lady I had in literally last Thursday. Now, if you look carefully, there's a scar there. So this lady has a long history of plantar fasciitis. She's had a plantar fascial release and is doing great, thank you very much. But she's also had some post-tib involvement. She's actually had a cortisone injection that settled down a post-tib tendinopathy, PTDD stage 1, and that settled down all the pain that she had within tib post. That's there. Porta pedis is there, guys, okay. But she's still got a little bit of local soreness there, and actually that's a new finding because she was all about plantar fasciitis, bit of post-tib stage 1, but now she's actually got some tarsal tunnel syndrome. So she's going to have a cortisone injection, and that's hopefully going to settle her down. So as if to prove the point, when I was finishing up with this lecture, the very patient came up and said, "Karen, can I take a picture?" She said, "Sure." This was a case I had a few years ago, fabulous space-occupying lesion, and that was a lipoma causing all the symptoms of a tarsal tunnel syndrome. But one of the things that we see is, actually in the very first video I ever saw, of video of a tarsal tunnel release, which was varicosities. So bear in mind, in that posterior medial compartment, we've got vein, artery, vein, nerve. Sorry, I've just skipped on a slide again. So varicosities of the posterior medial compartment, not uncommon. Now, jogger's heel, you may or not be familiar with, and that's an isolated compression of the medial plantar nerve. So it can get compressed at a couple of points, but classically as it kind of pops out from underneath abductor lucis or from the knot of Henry, which is in that area as well. So symptoms of tarsal tunnel, so diffuse plantar medial neuralgic pain, which would be burning, tingling, numbness, aggravated by activity, relieved by rest. We've talked about Tinel sign, sorry I'm clicking, and Valix phenomenon, but particularly look for this. There are some remote causes. You could have patients you've got that proximal radiculopathy causing pain all the way down a nerve. I've seen it rarely. It could be a proximal neuroma. I've seen that rarely. This is taken from an American source. Plantar fasciitis, I think there's an overlay. Plantar fibromatosis, not a million miles away. I've certainly seen patients who've had those crappy scarry knots that have been quite close to pressing on a nerve, and I've certainly seen patients who've had fibromatosis where it's pressed on the nerve and then problems within the nerve as well. So that's from an American reference. I kind of moderately agree with all of that. How do I treat? So my go-to now is to hydrodilate. So what I'll typically do is I'll mark up, I'll get the skin marker out and mark up the anatomy. So here's me marking up. So I've actually marked up where the plantar fascia is. Now it's not a plantar fascia case, but I've marked up where the patient would normally suffer from plantar fasciitis, excuse me. There's our muscle belly of abductor hallucis. Here's our artery coming down, so I know the nerve is just behind it. So here is our porta pedis. And there's our Valix phenomenon. We've had that slide before. And then what I typically do is I look to hydrodilate or hydrodissect. So I use a big old dose of local anaesthetic, maybe with some saline, maybe with some steroid, to try and stretch the tissues away from the nerve. And I've had some moderate to good results with that. That's very, very much my go-to technique in terms of beyond the basics of insoles, weight loss, etc. So I've had some moderate to good results with that, and put a big old dose in. That's an older picture. I've actually moved over to using nerve stim to be a little bit more accurate with. So effectively what we use now is a little battery, hook up to the needle and make sure that we've got the needle in the right spot by using peripheral nerve stimulator to make sure we're on it. So you'll find that as a paper if you want to find that. Myself and my then registrar, who's now a consultant, Aki, and I did a few years ago, so you can find that one online. All the nerve entrapments then. So just to finish off on tarsal tunnel, it's underdiagnosed. Find out where the porta pedis is. When you're seeing heel pain, look for it. You will see it. Joplin's neuroma. So I get perhaps half a dozen of these a year, and it's the first medial proper digital nerve, and I'll see it typically with that overpronating, yes, they still exist, patient that's overpronating with a bit of a bunion, and they're rolling onto that first proper digital nerve. Was written up in 1974, I think, and was written up as a series of surgical complications, actually. So if you're looking at that first nerve that comes through, that first proper digital nerve, and you'll see compression underneath the first MTPJ. That's typically where the entrapment causes. It's that bony bump of a bunion, a little bit of rolling over onto the nerve through toe off, and the nerve just gets caught at that point. Yeah, not 74, 71. Described by Joplin as a traumatic peroneal fibrosis after bunion surgery, so the nerves can certainly get caught. We'll come back to nerve entrapments after surgery at the end of this talk, actually. So medial plantar proper digital nerve, and that was the reference from 1971. Not actually a legendary rock singer called Janis, different Joplin entirely. And for those of you that are on my YouTube channel, you can go off and find that little video I did a few years ago now of doing a Joplin's nerve entrapment injection, and that lady did super well. Okay, next question. We're going to come back and look at heel pain a little bit. So what nerves are involved with plantar heel pain? There's a question I'll often pose. So which nerves supply the heel? Well, it's two. It's the medial calcaneal nerve that innervates the skin underneath the heel, and the Baxter's nerve, more correctly known as the inferior calcaneal nerve, that supplies the deeper structures, and there's a reference for that. I always like to leave references in where I can, just to show you I'm not just making this stuff up. Medial calcaneal nerve neuropathy is relatively rare because most of the time that first branch off the tibial nerve, which is the medial calcaneal nerve, the calc nerve often branches off quite high, becomes superficial quite quickly. So with a tarsal tunnel syndrome, the nerve is often spared because it's up and out of the way. So we do see isolated medial calcaneal nerve neuropathy, but it's not that common. So this was a lady that I had, and she actually had a Tinel sign there, but the pain was felt there. So if you get pain on that medial wall of the calc that's neuralgic in nature and it's not tarsal tunnel, do have a little look for medial calcaneal nerve. So this lady had an injection, so inject at the point of entrapment, and she did real well. See less than a handful of those a year, and I'll occasionally see it with tarsal tunnel syndrome, but it's something just to be on the look for. But it's typical, this particular lady's pain was there. If I'm seeing a medial calcaneal nerve entrapment, it's normally more that edge of that heel, as opposed to where you see the fasciitis. But don't forget, you can get an overlap of symptoms. You can get A plus B plus C. So again, just to kind of make that point that medial calcaneal nerve comes off quite high, becomes superficial quite quickly. So it's often quite difficult to isolate. It's also what makes sometimes, if we're needling verrucas, quite difficult, because oftentimes if you're doing a tibial block, I do my tibial blocks relatively low down here. Oftentimes I've missed the medial calcaneal nerve, so if I'm having to take a lesion off here, then I'll do a normal tibial block here, and I'll do a superficial medial calcaneal nerve block with local anaesthetic. Little tip for you there. So that's typically where you're going to get the pain. There you go, a little purple. Would we call that an ellipse? I guess we would. First branch off the lateral plantar nerve is the inferior calcaneal nerve, and lots of people have heard about Baxter's nerve now. Again, I don't think it was a thing when I was a student back in the 80s. Sensory components to the calcaneal periosteum, long plantar ligament, and some of the plantar lateral musculature. And again, you can look at nice little pictures online. I think this is probably the bestest picture, really, looking to see that you've got your medial calcaneal nerve coming off there. You can see it piercing the fascia and becoming superficial. But there's your first branch off the lateral plantar nerve, and it courses into the plantar lateral foot. So this is not such a good picture, but you get an idea of where the nerve goes. And look for this guy. Here's our Here's our heel spur. We know the heel spur, our friend the heel spur. So the nerve can be the subject of entrapment at a couple of points, really. It can be where the nerve turns laterally between the edges of the quadratus plantae and the fascia. I can't say that I've ever seen it. What I would say is every time I've seen a Baxter's nerve entrapment, so that would be a patient with plantar lateral neuralgic pain, there's been a heel spur. Every single time there's been a heel spur, because where the spur forms is where the nerve goes. So not the bestest picture, but this is a right foot, so this is lateral and this is medial. So this patient had plantar lateral neuralgic pain. If this would be where you get your plantar fasciitis, so it's a little bit further forward and a little bit further across. And then this is an MRI. You can see that deep musculature of abductor digiti minimi is fatty compared to your normal. What's that going to be? That's going to be flexure digitorum brevis. You can't quite see abductor hallucis there, but you can see there's certainly a difference on an MRI scan. As I say, always in my experience, always been associated with a calc spur. Not that you can't see it, but there you go. And in terms of injections, the injections are a little bit higher up. So this is old pictures of me injecting it in clinic. Do you know what? I've got access to x-rays now readily, so I'd always inject those with x-ray, so I can inject around the heel spur, because that's really nice to target under x-ray. But these pictures are probably about 15 years old, that picture, and that was me happily doing it in clinic. I'm a much bigger fan of injecting with some form of x-ray guidance now. Deep peroneal nerve, so cue to the other video that I put up earlier in the week. Deep peroneal nerve, as it goes over the dorsum of the foot, is prone to an entrapment. Divides into medial and lateral branch. The lateral branch supplies extension digitorum brevis and also the sinus tarsi for that matter. And then the medial branch courses down, pierces the deep fascia in the top of the foot and supplies the skin. ID12. It's a thing that we always remember from our anatomy books. And so we've got, I think I've got a little red circle coming in. Yeah, there you go, look. So it's supplying this area here. That's because this is a point it pierces the deep fascia. But this is the point where it can become entrapped. And so classically, it's over the second tarsal metatarsal joint, which is a really common site for arthritis. So you've got an arthritic joint from below, bit of shoe pressure from above, and entrapment ensues. So there you go. Most vulnerable over the second TMT, but it can also be trauma. It could even just be poorly fitting shoes. Anterior tarsal tunnel syndrome. You've seen it and you've missed it if you're not looking for it. This was a case that I did in clinic. Again, these pictures are about 15 years old now. So this is where the patient had Tinel sign, but this is where she had the pain. So you percussed there, she was painful there. So Tinel's there, pain there. So there's me using a whippy needle to get below the deep fascia. I've got this particularly thin brand of gloves. You can hardly see that I'm wearing them. But the injection needs to be deep to the deep fascia because that's where the nerve is. That's why it's called the deep peroneal nerve, guys. Superficial peroneal nerve is subject to an entrapment as well, described in 1945 by Henry, and it's a fairly rare one. I probably again see a handful of those a year. There's different areas that the nerve can be entrapped. It can be direct trauma to the ankle. So I think some of the cases I've seen have been post-ankle scope, because that's just where the lateral portal goes when you put the little camera in. But recurrent ankle injury or compartment syndrome, I think probably the times I've seen it most with the patient that's had recurrent inversion sprains. A couple of videos up on the site of patients being treated for SPN neuritis, Henry Monner's neuritis. They typically do well with a cortisone shot. Again, this video is originally aimed at injections, and I've even got a paper up on decompression of. So this is the nerve piercing. There's the deep fascia there. There's the nerve coming out of the deep fascia. This is where it becomes superficial, and that's that egress from the deep fascia, and that can be a little bit tight as well. So you can get these idiopathic, as in we don't know, nerve entrapments that sometimes need a surgical decompression. So again, if you want to follow that, you'll see a paper that I did a few years ago with my buddies Nicola and Helen. And then, not uncommon, doesn't have a name this, so I'm looking for somebody to call this Riley's neuritis. So the form of neuritis originally taught to me by that Riley chap, so it's not got a name, but the most medial branch of the medial dorsal cutaneous nerve, which is the most medial branch of the superficial peroneal nerve, as it goes over the top of a bunion. So this was a case actually referred to me by Helen, actually, who did the SPM paper with. This is about 10 years old, this picture. So Tunnel sign there, pain there. Not uncommon for me. In fact, really quite common. I get patients when they come through with bunions. I see bunions every day. They say, yeah, I get some shooting pains into the toe. So it's really, really quite common to see a little bit of low-grade neuritis. So let's start calling it Riley's neuritis, can we, guys? But I can't do it. Somebody else has got to write that up for me. You're not allowed to name things after yourself. Sural neuropathy. So the sural nerve comes at the back of the leg, and it's a conjoined nerve that takes its origin from a little bit of tibial and a bit of the common peroneal nerve, goes down the back of the leg and supplies the lateral aspect of the foot, and can be compressed anywhere along its course. But most cases that I've seen, and I've only seen a handful, have typically been after Achilles surgery. So it's one of the things I look for very carefully when I do Achilles surgery, is to make sure that I look for the nerve before I start doing gastroc recessions. And in theory, the nerve can be caught anywhere on the lateral aspect of the foot, and that's where it supplies. I've got literally one case on the go at the moment, and this lady here, so she's had some scans done, and oh, god damn it, this bloody mouse is so sensitive tonight. Sorry guys, you'll have to kind of scroll back. So we'd scan the nerves, and the nerves were absolutely fine on an MRI, but she's certainly got some sural nerve irritation and discomfort, but not bad enough for me to go and decompress. So those are the all 5 nerves. The only one we didn't talk about was a saphenous nerve, which is, because it's very superficial, I don't think I've ever seen a saphenous nerve entrapment, but it's the only one we've missed. So as mentioned before, whenever you cut, you can get issues with the scar. So with the Morton's neuroma, we know that we can get a stump neuroma form. So this is a case that was sent through to me. This particular one that was operated on in, I know I'm not going to say where, the West Country, and had a plantar incision. Not a good plantar incision for that matter, but she came through with a stump neuroma at the point where the nerve was cut. And so I injected her actually with alcohol, of all things. And this is another one. This is actually one of my old ones, where I'd done a second interspace neurectomy, and she'd come back 6 months later with a bit of a stump neuroma. This is one of the reasons I moved to a plantar incision. So now that I do plantar incisions, I don't see stump neuromas, because I can chase the nerve back further, so I don't get any regrowth. I get the odd crappy scar, but really not too many at all. So whenever we cut, there are risks of peri-incisional neuromas, but don't forget the stump neuroma is a specific entity. Tarsal tunnel release. So this is a lady I did a tarsal tunnel release. This is the abductor canal. This is portopedis. There's the abductor muscle there. And what I do with the surgery is I'll run some instrumentation down following the nerve, and then release the tightness of the adductor lucis muscle belly. But it's quite aggressive surgery. So you'll get the odd patient that comes back with there's a nice neat scar, but you can just about see it's a little bit thick and swollen. So that was a lady that had a tarsal tunnel release and was originally doing well. Then 6 months later, as that scar bound down around the nerve, so she came down and had injections into that little red thing just moved there. Okay, so that's now on the side. So one of the things I'll do is hydrodissection for a tarsal tunnel scar. Again, I can talk about that at length. This particular lady had flat foot surgery, so we'd done surgery to the heel, and we'd put a sinus tarsi implant in, but where the superficial peroneal nerve was coming down, she ended up getting symptoms. So you can see where the scar is. Then she had paresthesia and pain, soreness in the scar, but paresthesia distal. So we attempted to hydrodilate. So I've injected proximal to the scar, and I'm now injecting distal to try and do a scar busting injection. Actually, it didn't work in this instance, and we needed to go in and surgically decompress the nerve, but it's always worth a go. So the scar itself was very tightly bound down and required later surgical release, and then that took her, with that second surgery, to being a very happy patient. Alrighty, so that will do. So a little kind of a whiz through of nerve entrapments. So have a high index of suspicion when you see neuralgic pain in and around the forefoot. And thanks for listening.